Hello and welcome to another episode of Doctors Getting Coffee. Dr. Sil here, Junior Doctor from Sydney, Australia. Today, I have the pleasure of speaking with Professor Mark Brown. Mark Brown is a senior renal physician at St. George Hospital and a professor with UNSW, my old university. Now, Mark, or Prof Brown.
Mark will be good.
Thanks, yeah. The reason I wanted to speak with you today actually is because you gave me a tutorial when I was in 6th year. And I'm sure you don't remember because you've been teaching for decades. And it was one of the most moving tutorials that I've ever had. It was not a lecture, it was a story. And you shared with me a story, with the class, a story about a patient who had kind of acute kidney injuries and chronic kidney problems. And we traced her life, or their life. And you talked about the different insults, and we measured the creatinine at the different stages, and how sometimes it would get worse, and then kind of go back to a baseline and a bit worse. And we talked about the different illness processes along the line, and it kind of led to the point where dialysis wasn't working as well, and we had to talk about palliation, and eventually the patient passed away. Mm-hmm. And then, you know, we had goosebumps. I thought it was a fictitious patient, but then at the end of the tutorial you say, the reason I'm telling you about this patient is because I've just come from her funeral. Mm-hmm. And that has sat with me for a long time, and I've spoken to other students from that tutorial, and it moved us a lot. Because being a doctor is more than just a job, right? You have this lifelong connection with patients. And so thank you for that.
It's good that it's stayed with you.
Yeah. But I wanted to know what kind of led you to becoming a renal physician of all the organs?
Well, I was going to be a surgeon actually. When I was at medical school, I had this fantastic surgeon who, I'm not even sure how he and my father were connected. I think they'd played golf together or something at one stage. My dad wasn't in medicine. And he took me under his wing, and I would go to either Sutherland Hospital or Carina Hospital with him every Wednesday morning and assist him in theatre. And I probably did that for about 3 years. Wow. And he was a brilliant man. He taught me I could tie knots and all those things I can't do anymore. And he taught me a lot about surgery, but he taught me a lot about life as well. He was just a very kind, gentle man. And, he didn't kind of pull any punches. He was still very sensible, but he was a very kind man. And at the end of all of that, I do remember one of the things he taught that has stayed with me was we had a registrar walk in the middle of one of the cases and was saying something about so-and-so, another consultant, and he said, "Oh, look, he's very experienced." And it was almost like a bit derogatory, and a lot of people can be around doing things for a long time, but they have to keep their eyes and ears open to be experienced. And I thought it was a really pertinent comment. It's just not the length of time you're in medicine or engineering or whatever you do. It's how observant you have remained during that time.
If I think about the terms that I've been a part of, the ones that work best are the ones with a pretty open feedback culture. And companies too, by the way. And there's a lot of examples I can think of in like engineering where if people don't have their ears and eyes open for feedback, things can go wrong. Yeah. So that's a piece of advice that's stuck with you. How does that change your practice today? How did that bit of advice affect you?
Yeah, I've been conscious of that, I think, right from medical student days because of him. And interesting how you learn from people. So I've been conscious of that the whole time. I've tried to stay a bit aware of that. Although when I was a registrar, I had a general physician that I was working for at the time, and I was about to sit my exams, and you kind of think you know a lot of stuff, and you can get a bit ahead of yourself, I think, in retrospect. And he said to me, "Mark, do you know why we have to have medical registrars?" I didn't know where this was going, but I said, "Oh, no." He said, it's to keep us consultants absolutely up to date with the newest information. And I chuckled, and then he said, so why do we need consultants? And I looked at him, and he said to me, to protect the patient from all the harm that might do. And I thought,
that's right.
It was another kind of, he put me down quite nicely, because I thought, I knew a bit of stuff at the time. But it was, again, another comment that I have remembered, because it just, again, it's that reflection of integrating knowledge and experience is quite important, I think, as you go on.
And I think having a role model, no matter what people want to do in their lives, like good role models are really key, because they can provide insights that you can't learn from a lecture.
So going back, I was going to, at the end of medical school, I thought, I'll be a surgeon.
Yeah.
Because
Sorry, how old were you when you were assisting in these cases?
Oh, how old
was this like high school, or were you already...
No, I was in medicine.
Right, you had already started medicine.
But we did a 5-year medical course, went straight from school into medicine. So I think I was 18 or something when I started medicine. It was crazy. And we were the first of the 5-year course at UNSW, which later got scrapped and returned back to 6 years. Probably reflective of how we turned out.
I don't think so.
But interesting, talking to some people along the way, it kind of turns out I think they were making that course up year by year as we went.
Okay.
So
figuring out what works. Trial and error.
Yeah. So it got changed. No, so it's probably not no more than 21, 22 or something like that. So
you were going for surgery, and then what happened?
Then I did. I was actually an intern here at St George.
Wow.
Yeah, in fact, I've spent 39 years of my career at St George.
Fantastic.
So I was doing an internship here, and I did a surgical term first in urology, and I really enjoyed that. That was great. But then, little into the year, I did I did an orthopedics term, and they were great. There's one of the surgeons who I won't name. He's a surgeon in Sydney now, an orthopedic surgeon. He used to let me do pins and plates and things with him supervising as the registrar. Until one night, he came in the next morning. He said, "Oh, Mark, that woman we did last night." I said, "Oh, what happened?" And he said, "No, she's done well." He said, "She's fine, but it turns out it's matron's mother." We used to have nursing matrons back in those days, like the director of nursing equivalent.
Yeah, the word got out?
Well, none of us knew. So the registrar and an intern had been doing a pin and plate on matron's mum, which wasn't a good look.
No.
So we had to kind of cover that up. But that was a good term, but I got very interested in the medicine during that term, because as a junior doctor, you're somewhat left on your own to sort out the medicine in that term.
Yeah, for those who don't know, when you're the junior doctor on a surgical term, you kind of run the ward, while more senior people are doing the operations. So all the peri-operative complications, the pre-op preparations, and the post-op complications, pneumonias, clots, all that kind of thing. Sometimes you're the first person there to sort it all out.
Yeah.
So you got to know the medicine.
Yeah. So that was interesting. And then I did haematology. And again, you're lucky in life. I worked for a wonderful man called Bob Pitney, the Pitney Building.
No.
Yeah.
Wow.
And he was just a remarkable man, an astute physician, an astute haematologist, but just a good soul. And he took me aside at one point and said, "I really think you'd be suited to be a physician." And I don't know what clicked, but it was at that point I thought, yeah, this is where I need to head.
Were you conflicted at the time, or before that conversation, about what you were going to do with your career? Or were you looking for a kind of a permission from a kind of a role model to open up that option to you?
Yes.
Or because I can imagine that if you've had like someone who's you look up to and who's guiding you, building you up for surgery, you would have felt like that's kind of what you had to do, but also what you wanted to do. But maybe having another role model open up a second door, did that change your mind, or was it something that was more internal than external?
That's probably a bit of both. I really don't know. I didn't feel particularly conflicted at the time. I think that, you know, sometimes in life things just go down a pathway and then eventually the door opens and you may not have seen that door coming for a while.
Yeah.
And I think there was more that. But also too, I think to have someone senior and someone you respected, probably more to the point, you know, say, I think this is a pathway you could go down, makes you think a lot more about it. So that was the turning point, I think, when I decided on physician style of work. And then renal, I just did a renal term, found it very interesting. Thought there were a lot of, even then, thought there were a lot of opportunities of things that could be developed.
Oh yeah?
And it was kind of exciting, seemed to be at a very early phase, and did some obstetric medicine in that term, and well, not really did obstetric medicine, but had a look at a couple of disastrous cases, and thought, you know, that's another kind of angle to this job.
With the eclampsia and the high blood pressure issues that come with
Yeah,
pregnancy?
I can still remember back the kind of cases we saw. We didn't get called much to delivery suite or maternity, but when we did, it was a nightmare of a case. It was usually, you know, late presentation, uncontrolled hypertension, bleeding, DICs, renal failure, the whole bit.
Right.
And at that stage, if you couldn't get a baby past 34 weeks, they didn't survive. Right. So it was pretty horrible. So, yeah. But
with Dr. Pitney, him being just a good man, I find that a lot of physicians are good people. Do you think that doing this job, working with people who are unwell during the worst times of their life, do you feel like that makes you a good person, or do you feel like it's good people that kind of go into medicine? I feel like people who go into medicine are very young, and you know, their identity is still developing a lot of the time by the time they get in, and over the course of their life they kind of, you know, become more compassionate and kind, or burnt out and go the other way. But yeah, do you think, like, for example, with Dr. Pitney, it was the fact that he was a good person intrinsically before becoming a doctor, or was it being a doctor that makes him a good person?
You suspect he was always a good person, but I think medicine gives you the opportunity, doesn't it, to actually explore that in your nature. You know, a lot of people have that intrinsic capacity, but might not either find or be given the opportunity to utilise that as their life goes on. And whereas medicine is a blessing to allow us to do that. But if I look, most of the doctors that I know, you know, 95% plus are good people. Yeah. And you know, I have some very close surgical friends, and they're very good people. And very, you know, the same. I don't think it's physician, surgeon, obstetrician or anything. They're just...
Yeah, there's a lot of stereotypes that are so unfounded. But, I agree. Throughout all your training, like, I know burnout's a big issue these days. I'm sure it was as well in your training days. Did you ever experience burnout? What was some of the tougher times during your training?
Yeah, look, the terminology is a bit tricky, burnout, but
sure.
Tougher times, definitely, absolutely. When we were medical registrars, there weren't many of us for a start, and there were no specialty registrars. So the plus side of that was that you did everything. You'd be on a night shift, and you'd do your own lumbar puncture, you'd put in your own pacemaker, you'd do whatever, you know. So you got a lot of experience, but number one, it wasn't directly supervised, so that wasn't great. I can remember the first chest drain I put in was as a JMO. I was in the Canterbury emergency department after hours, and there was only 2 of us on for the entire hospital, and the other JMO was in maternity, stuck there, and I had a young kid come in there with, after an MVA, ruptured spleen, which we diagnosed in those days by putting a a needle into the abdomen and seeing blood. We didn't have the ultrasounds and things. And a pneumothorax. And I hadn't put a chest tube in before, and there was no one there to do it, and no one coming in. So I rang a surgical registrar at St George, who I'd done a term with here, and who was just a godsend, and he took me through it over the phone.
Wow.
And that's how it was done. Now, things have changed so much for the better since then, but I still remember that case, and the fact that I remember it means that it's had some effect on me. So the supervision's much better now, so those sort of cases are hopefully non-existent. But then, the hours were terrible. We would do, the med-reg shift was, the weekend one was Saturday morning, you'd start at 8, and you finished Monday evening at 6 or whatever. And you hoped you got some sleep along the way. And that, that wasn't good. And you were studying for your exams as well, and you were trying to, carry out relationships in life as well, and there was a lot of collateral damage.
Right, really? So it personally affected your personal life?
Yeah,
because of those hours? I can imagine,
It did.
And then by the time you get home, what energy do you have after 72 hours of that?
And then you've got to put that into study. Yeah. So they were difficult times, to be honest. They were good times too, because you form very strong bonds at work with people.
Yeah, it's a camaraderie rather than just a colleague. I really admire that.
Absolutely. So there was the plus side to it, but I'm glad it's not that way anymore. It should, it's much better.
One of the questions, and you've alluded to it already, is that I wanted to ask is about how patients stick with you throughout your life. You're talking about a young patient you saw as an intern, as a resident.
As an intern.
An intern. Yeah. Do you often think about patients from when you were younger, from your internship and resident years? Because I'm a resident now, and I've seen a couple of tough cases, and they definitely stick with me.
Probably less so from those years than from, say, early consultant years.
Because then the responsibility is yours, but you're a early consultant. Kind of. Is that the issue? Or why,
I hadn't actually thought of it along those lines, but that's probably correct. But I particularly remember a pregnant woman who died, and that was tricky. I'd actually, back in those days, I was a very junior consultant, and I came in and went to theatre with her. The surgeon, the obstetrician, we decided we had to deliver her. She was 28 weeks. Terrible preeclampsia. We had to deliver her, and I went into theatre and tried to help with the blood pressure control of things and so on. That was about 2 a.m, and then I came back and saw her about 6:30 a.m, and she was, pretty stable, I thought. Baby had been transferred out to a neonatal intensive care unit, was doing okay. And I went back to start my clinic about 8 o'clock, and got a phone call about an hour later to say she was dead. And I worked with the coroner to try and find an explanation, and we couldn't. But that was the medical side of it, which is almost irrelevant. Well, not irrelevant, but because finding a cause would have been great, and we never did. But having to sit there with the husband and tell him what happened, so that's that's still difficult.
And I went to Tanzania for an emergency medicine elective.
Wow.
And there's no antenatal care where I went. Small town, and I saw a couple of pregnant young women die from what was certainly eclampsia. And very pregnant, and they're thinking of perimortem C-section kind of things during resus, and they just don't have they didn't really have resources for a neonatal intensive care for that kind of a situation, and it's horrible to see someone pass away. It's horrible to see a pregnant woman pass away, and it's horrible to tell the husband that one day he's got a wife and a baby on the way, and the next day he's alone.
Yeah, and bizarrely, I got an email from a fellow consultant recently. Did I know so-and-so, a woman who died in pregnancy all these years ago because they're just seeing a relative of theirs who's now pregnant. Wow, it just keeps coming around. You know. But I think with all those cases, so it's kind of what you learn from them.
I think what's kind of amazing, and not necessarily in a good way, about being a physician is because you have to go from that conversation with the husband to your clinic or to your next thing. Now it's like an ED, now they do hot debriefs and cold debriefs. So a hot debrief. Sorry, a couple of things just to take a step back for everyone watching. Eclampsia, which is what happens when you're pregnant and have high blood pressure. The blood pressure gets so high when you're pregnant, it damages organs, it damages the brain, you get seizures, it ruins your kidneys, and blood pressure becomes higher, and so it can kill people. In Australia, it's luckily usually caught early because most people go into antenatal care, but some people don't, from a mix of reasons. So that's what we've been talking about here. And sometimes you see horrible things, and then you do an after-hours shift, someone dies, you have to update the family, and then you get a rapid response, you've got to go to the next patient. So, there's views around repressing feelings, and actually I think when you're at work, sometimes you have to be functional, and you process it after work. Do you have a good support network personally to talk to and that kind of thing, or
my poor wife.
Same here.
I think the beauty is she did nursing, and so she understands the discussions. I suppose phrased correctly, anyone can understand the discussions because they're more about your feelings and emotions than technicalities of a case. But I think that's also been helpful. But the burden's been on her a bit to hear all these stories over the years. But that has been a great support. But I've also been really blessed to work in a fabulous department all this time. And, we can chat amongst each other and, about a range of issues amongst our colleagues, whether they be a case or whether they be a personal issue. We are actually good friends in our department as well as good colleagues.
That's wonderful.
That's been such a blessing.
Something you said earlier that's kind of just hitting me now because it's something I do, was around how the medicine was the irrelevant part of it, and it was the emotions that was the kind of core focus, or just the interpersonal situation with families around hard situations. And I just realised that's actually my defence mechanism, is to over-intellectualize horrible things and try and describe the pathophysiology, or try and describe what's happened medically, and to try and protect myself from going towards that. So that's an interesting one. That's it. Anyway, that's just something I need to be aware of myself, because
I think
at the end of the day, I don't know if that's the right way to process it, but we all have our defense mechanisms.
We do, and I think in medicine that's pretty universal, and I think that we still do that. I mean, I know I still do that, but I'm more conscious that there's much bigger issues at play than just the mechanics of what the case was all about. Whereas I'm not sure I was as conscious of those early on.
And in your junior, or I shouldn't say junior, in your early consultant years, what was the reason that those patients stuck with you longer? Was it because you hadn't had the kind of experience you have now, the kind of sense of control that you might have now? Was it a...
I don't think so. I think it was just that there wasn't the experience back then, I think, and so you felt more what should I have done that I didn't do?
Right. The what ifs.
Yeah, and I think you can get to a later stage where you can more objectively see that you've tried the right things. But I think too, coming back to having a good department to work in, you can actually then discuss that case with your colleagues to make sure that there wasn't a step you missed.
And doctors are human, and mistakes happen, and there aren't guidelines for everything.
Exactly.
Yeah.
No,
So it is up to your.
that's
Sometimes there's no perfect answer. And hindsight is 20/20. Yeah.
Yeah. But even in later career, I think you still get cases that are going to stay with you. I mean, in my recent years, I had a lovely man, older man on dialysis that I've been looking after for the best part of 25 years, I think, on and off since he started his chronic kidney disease right through. But he had a family relative who just took to me and did not like me at all and just kept at me, and she'd fly in from overseas and go straight to the patient complaint unit, and it just went on and on. It was relentless. And yet he was a very nice man, and he and I had a good relationship, and I could see that his life was deteriorating, his medical conditions were worsening, and I'm generally conscious these days of wanting to make sure people have so-called good death.
Yeah.
And I tried to put, systems in place and palliative care connections and advanced care plans in place for him. And none of that worked with that person and that relative of his. And he ended up dying a pretty horrible death, pretty well bleeding out in a radiology department. And, I won't forget that for a long time either. I'm not sure what I could have done differently, but, maybe I should have had different ways of establishing a better relationship with the family, I'm not sure. But that case will stay with me for a while as well. So I think throughout your whole career, there's going to be particular cases that stay with you.
Yeah.
But to keep the perspective, I mean, they're vastly outweighed by the fabulous things.
And I feel like we've focused on negative cases in the chat, but I do that because that's what's something I'm interested in at the moment. But I also think it's a privilege to be one of the people during a horrible time. Like, that makes the thing better, even if it's these are terrible cases. The fact that you're one of the people during those cases, that's an honourable and admirable thing to make a bad thing even a little bit better. Prof, when you're working with people with renal disease and they go towards the end of their life, and you work closely with palliative care and Dr. Brennan, you see a lot of death. And does it change how you feel about your own mortality?
Yes, it does, I think. I don't think I've been as conscious of my own mortality, except maybe in the past 15 years or so doing the renal palliative care stuff. But not in a negative way at all, but just more in a way of, trying to live out, the best life you can. But I hope I can maintain my own principles when it comes to end of life, and that is not to have prolonged suffering, and not to inflict prolonged suffering on those around me. So I hope that I can carry that out, but we'll see.
Hopefully not for a long time,
Hopefully
of course. Yeah, I think it's a marker of maturity of a society to start going towards palliative care and accepting the idea of a good death and not just fighting death, which it's a win-win, because it's also better for doctors. Like, obviously it's better for patients, and patients have to come to that their own way, and that's a different conversation. But it means that there are limits of care in place from a doctor's perspective, and we're not just fighting a futile fight, which is a horrible thing to try and do when you're just treating, putting chest drains in someone who's just morbid, like adding to someone's suffering, which I've been involved in resuscitations of people that really should not be resuscitated, and that stays with me. And yeah, it takes a bit of maturity to society to get to a point to accept that like death is a part of life.
And we're not at that point in society yet. And I think partly the reason for that is we haven't had strong societal leadership about those discussions. You know, you can see politicians, for example, are very nervous about having these discussions because, you know, it could be seen as a negative thing to do and puts them in a tricky situation. But we do need to have, you know, societal discussions about, it's really a discussion largely about medical technology, you know. I mean,
what do you mean?
I have a slide that I use at the end of my talks on renal supportive care, which says that there's what you can do, but then there's what you should do.
Right.
And so from renal, we can put anyone onto a dialysis machine, more or less. Not 100%, but more or less. But you shouldn't always do that for the patient and family's sake. You know, and similarly, you know, the technology and cardiac medicine and chemotherapy and everything has just advanced so much. But we have to just take a deep breath and go, okay, that's fantastic. But what is the right place for that, for this patient? And it's the families that are as affected as the patient, really. I mean, the families will often, through love, want everything done for their elderly parent.
Yeah.
You know, who, you know, from a medical perspective meets the criteria that they will not go well.
Yeah. They'll ask, and that's a common thing that registrars have to talk to families about, where, you know, in their case, we do things called NFR forms or resuscitation forms. I forgot the exact term of it, but we have to talk to the family about what they wish, what the patient would want in a cardiac event, or the patient themselves. And often, you know, I've seen families advocate for CPR on a 95-year-old, and it's like, if a heart stops, a CPR is not going to change that outcome in a 95-year-old with these comorbidities. It's always a case-by-case basis, but it's this attitude of let's do everything we can to get them even an extra day. But in a sense, it's, anyway, that's a bit extreme, but it's a form of harm to overdo this stuff.
I think the tricky thing in the discussions that I've come to learn is trying to understand where that family is coming from. And it is very often out of love. It's just misguided, understandably, because they're not coming from the same understanding of the case or what the harms might be as you're coming from. But if you can tap into that aspect of the discussion with them, that I can see that you love your dad, and I can see why
you want what's best for them, which is not always.
But I can tell you what's going to flow from this, and it may not be, you know, the right thing for them. And I think one of the ways to turn it around then is to say to them, look, you're loving your dad in wanting to get all these things done for him, put him on dialysis or whatever. But really the best way to love your dad now is to help us look after him and keep him really comfortable and you know, that he has a peaceful life from here on. And that's
dignity,
you know, it takes time with those discussions.
Yeah. You can't change someone's mind in one chat.
No, definitely not.
Now, you've done a bit of work in homeless health as well, haven't you? Which I wanted to ask you about, and how you see the future of homeless health and how that's going. What has been your involvement?
So just over 10 years ago, my wife and I established a medical clinic at the Mission Australia Centre in Surrey Hills, which is a shelter for homeless men. So the guys come in from various places. They'll be referred in there, or they might be referred through Mission Beat from, Living Rough, or they'll come from jail to there because there's nowhere else to go.
Right.
And around that time, we'd had some connections with the Mission Australia Society, and there was a medical report that had come out basically showing that something like 80% of them had never had a medical assessment in their life, like never. And so, that opportunity came up to set that up, and we've been running it since then, and we've now got, it's through the St George Hospital again, the camaraderie and collegiality in this place is fantastic.
Yeah.
We've got another physician now that's joined us. We've got nurses who'll come and do vaccinations there. We've got a nurse who'll come and do the fibre scans to look for the chronic liver disease. We have had a mental health psychiatrist come. That's not happening at the moment, but all of that has developed over that time, and it's been good to be able to.
I'll share a link. Is there a website for it or anything like that?
No.
No, it's just a walk-in kind of.
Yeah.
And you work directly with services. Oh, okay.
Yeah, we published it in one of the journals, some of the outcomes, but.
Yeah. And is that funded through the state government or through St George's Hospital that funds it? Or I don't talk about funding.
I'm the only person with a department that has no cost centre. We have no money for this at all.
Yeah.
So everyone does it off
It's
their
all
own
voluntary,
bat.
yeah.
There's a little bit towards the psychiatrist money, but not very much. But the rest of it is unfunded. And you mentioned in that question the future of homeless health. It's a long way behind the eight ball. It's pretty neglected, the whole side of it. There are very well-meaning people trying to help out at certain levels in the district and at ministry and other NGOs and that, but it runs on a prayer. It runs on no money, and you're always looking for people to volunteer to do this sort of work, which is great if you can get someone to commit long term, but these are not the sort of clinics where you can just come in and go out and not establish relationships.
Right.
So that's a bit tricky as well, but I'm hoping to spend a bit more time trying to escalate the profile of that problem, statewide at least, because it's got to be better managed than it is now in terms of an approach to healthcare. It's pretty terrible.
Yeah, and it needs as much mental health input as physical health input, and I don't know why don't get you started, hey?
Well, it does, but I mean, at the moment our psychiatrist is on secondment for 6 months or whatever, and I cannot get a replacement to do one clinic a fortnight. That's all we're asking, and I can't get it. And I think that partly reflects the shortages in mental health in general, but it also reflects the approach to homeless health. I mean, if there's a shortage in the renal department or the cardiology department, you just advertise and get someone.
Right.
A shortage in this, and it's not that easy.
It's just not seen as one of the sexy things to do in your career kind of thing, right?
Yeah, correct.
That's sad.
And these are guys with terrible life stories, just amazingly bad life stories.
Yeah.
One of the guys I saw early on in the process, he'd come from a drug and alcohol background, but when you got into it, he'd been abused as a kid. For his 13th birthday, his dad thought he'd shoot him up with heroin for his birthday present. For his 14th birthday, his uncle gave him a job selling cocaine at the Cross. Well, what hopes the guy got, And then he ends up there, and so you're starting from scratch when he's, 21, just out of jail, and you're trying to, start from scratch and work through all those things. He had Hep C that he didn't know about, a whole range of medical things. But then the much bigger issues for him is trying to getting back on track life-wise.
Yeah, well, that's right. And how much can you do as, you know, one appointment a week with a doctor kind of thing? It's
They got great counsellors and
good.
things
Yeah,
in
that's
there.
it. So it's a multidisciplinary.
Yeah.
I think so. You're involved in the medical side of things, but they have other
They
people
got
at Mission Australia. Yeah,
terrific things there. But
that's
again,
wonderful. Yeah.
they got, you know, they're counting
Struggling
on people to donate money to run that. You know, so,
All right. Well, I'll put a link in the in comments to Mission
Great.
Australia, because this is really wonderful stuff.
Good on you.
So, in the next 10 years of your career, what are you hoping to achieve in the next 10 years? Is there things? It sounds like you're working on this clinic a bit more. Is that the main thing, or is there other things as well you're working on?
I think the two areas I'm now mainly working in is that in terms of systems side of things, not so much more on we'll continue doing the medicine, but more on trying to get the systems changed, and just still working on the renal supportive care, renal palliative care stuff with Frank Brennan, and we're currently in the midst of a international collaboration on developing a curriculum for that, so that doctors worldwide can have a standardised learning process about renal supportive care.
Wonderful. Is that in the format of an online course they can do?
We're heading towards something like that, yeah. So I had to write a section on nephrology for the non-nephrologist, because
I like that.
You know, then the pal care person who's doing most of the supportive care work in, you know, South Africa is not a nephrologist, but then there'll be a nephrologist who'll learn the pal care side of it, or working in some other country. Yeah.
Palliative care it feels like such a young specialty. It's something I'm actually thinking about a lot. I haven't gotten a palliative care turn yet as a JMO, but I look forward to talking to Frank more about life as a physician in palliative care.
I think the opportunity for a lot of young doctors now is the opportunity to do dual training. For example, in our department, we've got a fabulous nephrologist who's dual trained in renal medicine and palliative care.
Oh, great. Yeah.
She's just brilliant.
Yeah.
And I think those opportunities are going to open up. I think palliative care is now evolving more into what it always wanted to be, and that is not just about the last week or two of life, but the chronic trajectory.
Exactly. You know, the second you get diagnosed with that, life-limiting illness, even if it's a year or 2 years, multiple ALS can take years, but getting involved early, that's the way to go.
Yeah, exactly.
Yeah.
And so, you know, if you want to be any doctor really, but if you wanted anyone who's dealing with chronic care, but even, to be honest, even critical care, I think there's opportunities for dual training.
Really? In critical care as well?
Well, if you think about critical care, a lot of my senior colleagues in critical care will say to me, oh, you know, we had someone come in and we spent a lot of time going through the family with them about, you know, palliative approach to things and what we would do from here on. And they're not all going to die in that emergency department, you know. And sure, they'll be handed on to another team, but I think if you've got expert background training yourself, you know, you might, maybe a diploma is all you would have needed to do rather than a whole specialisation. But that sort of thing, I think, is an enormous benefit in that setting. But, you know, if you're doing neurology or cardiology or respiratory or anything like that, if you're dual trained with palliative care, the opportunities to really look after people and their families just opens up enormously.
That's right. Yeah. I will definitely do a term on it in my kind of planning on it. So, Mark, you've had a lot of leadership roles in your life, and you've worked with junior doctors that are good and maybe some that are not so good. What are some of the attributes that you find are really important in a good junior doctor?
I think the main thing is having an interest and being, you know, excited about being in the role. I don't mean you have to jump up and down about it, but if someone's interested in that job and what they're doing, I think just human nature is you'll be more interested in helping them develop as well. So I think that's a first key element. And I think secondly, that they want to learn That's really important. And again, that bounces off you and you're really keen to help them learn.
This goes for medical students too.
Absolutely.
Yeah.
Absolutely.
And you can tell a lot by someone based on the questions they ask, I think. Yeah. That shows how interested they are and what they're thinking about while they're next. Yeah. Sorry.
No, that's very true.
Yeah.
And then I think the third thing is how they interact with the patients, the families, and everyone else on the team. So, you know, the cleaner that's cleaning on the ward, you know, the allied health team, the nurses, the doctors, their colleagues, you know, are they all on a WhatsApp group that they've formed together because they actually like each other? All that, I think they're really key elements. We've been pretty lucky, I must say, and I actually see a increasing maturity and an increasing goodness in the junior doctors that we've been getting. Great. I think it's never been bad, but I just think it's better. And I think you guys are much better than I ever was at sorting out your life and some balance in your life. I think that's very admirable. Yeah.
We get given the opportunity to have a bit more work-life balance though. I have never done a Friday to Monday 72-hour shift, for example.
But I think you handle it well anyway. I think you're a lot more cognizant of it. I mean, I don't think I matured early enough, to be honest. Whereas I think the junior doctors now are far more mature than I was at the same stage, and I think you're therefore thinking a lot more about life and, you know, the complexities of it and the balances of it, and much better than I think what I did. Yeah.
So on that note, now do you have like systems in place in your life, like a morning routine? Because you do so much, you're extremely productive. Do you have a morning routine that you use to kind of get ready, or a night routine, or systems in place?
A lot better now.
Yeah.
I mean, early in my career, I did too much on the work side of things.
Yeah.
And, you know, come home and still work at home, and that went on for too long in retrospect. So time again, I wouldn't do that, and I would just achieve goals a bit later than I achieved them before. I think that would have been a much more mature approach, a worldly approach to it.
What slowed you down? What was, because it takes a lot of insight to not just go gung ho on the career pathway. And depending on your career, you can't you can't do part-time neurosurgery no matter who you are. No one's doing that. What for you? What made you kind of take a step back?
It's interesting. I'm not entirely sure of the answer to that question, but one of the things that's happened is along the way you'll get certain recognitions. You know, you're made professor or whatever. And it's all great, and you go out for dinner and you have a champagne and whatever. But the next day you kind of wake up and you're still the same person. And so I think you kind of realise that these milestones that you might have set yourself are not that fantastic compared to other parts of your life. And so I think for me a little bit of it has been that, just coming to the realisation that these different milestones, you know, publishing this paper or, you know, getting to this point in your career or whatever, they've all been good, but, you know, they weren't the most important thing. So probably...
So what was the most... Because, you know, we've talked about you wanting to live life as good as possible, given all the exposure to end of life you've had, and now kind of realising that sometimes the academic achievements aren't everything, although very important in a meaningful career. What do you find is the most important parts of life to live a good life?
I've got a very good friend who summed this up for me quite some time ago, and he said, and I think he's right, he said the first thing is you've got to have strong relationships. And secondly, do things for other people. And thirdly, have a spirituality. And if you think about those three things in medicine, relationships, we're so blessed. I mean, I'm lucky. I've got great relationships with my family. I've got a fabulous wife, but the kids are great. We've got 4 and another almost 1 on the way, grandchild.
Wow.
We see them all the time.
That's great.
The family's together a lot, and that's just been fantastic. I've got friends who I went to school with, friends who I went through uni with, and lots of friends that I've met since then, inside and outside of medicine. The relationships side of it at a personal level has been so helpful at different crisis times along the way, and on a day-to-day basis is great. And then in medicine we're even luckier because it's such a privilege to be a doctor, and we can have relationships with all these people that you haven't met until last week, and you can continue those relationships in many aspects of medicine for 30 years or more. So that relationship side I think is important. Doing things for other people, I think I'm more cognizant of that since he talked to me about this. But again, that doesn't have to be running a clinic somewhere or going to Tanzania. It can be as simple as being cognizant that I'm a doctor, whether I'm an intern or a senior consultant, and I've got a patient and family and other staff and students and things that I have to care for and do something good for them.
Like a nice conversation, and I'm deeply grateful that you've taken the time to do this.
It's a pleasure.
Thank you so much for your time. Sorry, last question, and it's about the spirituality. How did you find your spirituality? Because as a bit of context, I kind of wish I was religious. And I was raised Catholic, and I kind of am not. I just like when I think of the probabilities of whether humans kind of came up with these stories versus whether they're real or not. To me, the probabilities don't play out in favour of the kind of supernatural or whatever you would use to describe it. But I also think that I haven't been tested on that, because it's all like as a agnostic or atheist, it's all good to say that when life's going well, but it's a different thing when life gets tough. And I haven't been challenged by life in a way that challenges, like what's my meaning kind of thing, because things have gone very smoothly. I'm very privileged and grateful for that. But for you, what is your spirituality? How did you find it?
Later years, just 20 years ago, really came back to Christianity and I think what I would say to you is there's a vast difference between spirituality and religion. Religion is very much constructed, and that's why there's so many religions, but everyone's got a spirituality. Frank Brennan taught me this, that that innate questioning of who am I, where do I sit in the universe or the spirits, what is my purpose in life? This is not human so much as spiritual. And that then can dovetail nicely with some religions and not so nicely with others. But I think Frank's right, everyone's got an intrinsic spirituality. And for some, there might be Christianity or Buddhism or whatever, is a religion that can then intertwine with that and enhance. So,
Mark, what a beautiful way to finish what has been a very insightful and wonderful conversation. So,
my pleasure.
Thank you so much.
Thanks, Phil.